In this lecture, we will discuss pathological Q waves and R waves, including their EKG features and clinical significance. Myocardial infarctions often manifest with pathological Q waves, especially after one of extensive size. These pathological Q waves are wider and deeper than normal Q waves. If you recall, they tend to occur about 6 to 16 hours following symptom onset, but may appear earlier at times. It was previously believed that pathological Q waves are permanent and represent a transmural infarction, that is involving the entire thickness of the myocardium. However, recent evidence suggests otherwise. For example, pathological Q waves are believed to diminish in amplitude and can actually resolve in about 1/3 of patients following an inferior MI. Furthermore, cardiac MRI studies suggest that pathological Q waves can also be present from extensive subendocardial infarctions. So how can we identify these pathological Q waves on the EKG? Well, the criteria require that pathological Q waves be present in at least 2 anatomically contiguous leads. And remember, the reason we are able to use these pathological Q waves to localize an infarct is because they are the same leads in which the ST elevations occurred. So the criteria is split between leads V2 and V3 and then all the other leads. In leads V2 and V3, pathological Q waves are defined as Q waves that are greater than or equal to 20 milliseconds in width, as well as the presence of a QS complex in those leads, okay? Or so it's one or the other, okay? A QS complex, it means that the entire QRS complex is represented by one negative deflection, okay? So let's look at that here. So the first one here is V2 through V3, and the width, so imagine this is maybe V2 and V3, the width here, okay, is at least 20 milliseconds. So remember, 20 milliseconds would be half a small box, okay? So it's clearly, over over a box here. So that would be 40 milliseconds. So we meet that. Or a QS complex, okay? So QS complex simply means that it goes down, okay, and then up. So this is our QS complex, okay? There's no R wave and there's really no S wave, but it's the first. So we have a P wave, then we have a QS complex, then it goes up and then into our T wave, okay? So this negative deflection, we call it a QS complex, okay? So you want one or the other, okay, in V2 or V3. Now with all the other leads, pathological Q waves are defined as Q waves that are greater than or equal to 30 milliseconds wide and at least 1 millimeter deep, or the presence of a QS complex, okay? So now the other leads, okay, all right? And what we're going to see here is that it needs to be 30 milliseconds wide, okay? So in this case, we can clearly see this is 30 milliseconds wide. We see our QS complex, which is also present there. And obviously, the depth of these Q waves is what? 1, 2, 3, 4, almost 4 small boxes. So clearly 4 millimeters, much greater than the 1 millimeter depth, okay? So that's the other leads, okay? So if you imagine V2 through V3 as this criteria here, and then all the other ones, you can use that other criteria that we went. So there are some normal variants that can exist in some leads. For instance, individuals with an electrical axis between positive 60 and positive 90 degrees often show a small Q wave in lead AVL. In addition, leads V5 and V6 often have small Q waves, which we refer to as the septal Q waves. An isolated QS complex is generally acceptable in lead V1, as it may be due to a missing small R wave or a misplaced electrode. Lead 3 sometimes can have a large isolated Q wave, which is referred to as a respiratory Q wave and varies in amplitude with respiration. Lead 3 may also have small Q waves unrelated to respiration in individuals with an electrical axis between negative 30 degrees and 0 degrees. Okay, so probably more than you needed to know, but it doesn't hurt to be aware of some of these normal variants. And finally, it's been suggested that R waves may be used to diagnose a previous MI. The pathological R wave criteria includes an R wave greater than or equal to 40 milliseconds wide in V1 and V2, okay, as well as an R to S ratio greater than or equal to 1 with concordant positive T waves in the absence of a conduction defect, okay. So now this pathological R waves help us to potentially diagnose a prior MI, and we're again looking at V1 and V2, okay, so these were the Q waves, now we're looking at our pathological R waves. We want an R wave width or duration that's at least 40 milliseconds, which is one small box, okay, and you can see that here. Notice our width, okay, here's the onset and here's the top of the R wave, okay, so our width there is greater than that. We're looking at an R to S ratio that's at least 1, so greater than or equal to 1. This again is our R wave, This is our S wave, and we can clearly see that the R wave amplitude is greater than that of the S wave. Okay. We also want concordant positive T waves. Okay. So we have a positive upright QRS complex, okay, taller R wave than our S wave. And then also if we look at our T wave, which is indicated here, it's again upright. So we have concordance with our T wave in the QRS complex. And also you want no conduction defect present as well. All right, so let's review what we discussed before we end here. So pathological Q waves, remember, these occur about 6 to 16 hours following symptom onset. They sometimes can appear sooner. We use them to diagnose and localize prior MI because remember, these are the same leads that the ST elevation occurred. They appear in transmural MI as well as in extensive subendocardial MI. So they're not limited to transmural MIs, okay? They have a decrease in amplitude, or they can resolve in about 1/3 of those with after an inferior MI. Now we talked about the EKG criteria, which is this here, okay, and one of the main things you should take away. So in V2 through V3, you want a Q wave width of at least 20 milliseconds or a QS complex, okay? And remember, the main thing here I kind of covered up is you want it in at least 2 anatomically contiguous leads, okay? So it can't be just in V2, you need them in V3 as well. The other leads, okay, you want them at 30 milliseconds wide or at least 1 millimeter deep, okay? Or you can have the QS complex, all right? Now we talked about a number of normal variants that you can have listed or keep them as a reference. We won't go through them again. And then we talked about these pathological R waves that can help us also diagnose prior MIs, okay? The criteria here were in V1 and V2 specifically, and in this case, we want the R waves to have a width of 40 milliseconds, one small box, an R to S ratio greater than or equal to 1, concordant positive T waves, and you also want to make sure there's no conduction defect present as well. Well, that's the end of this lecture. We discussed pathological Q waves and pathological R waves, including their EKG features and clinical significance. I hope you learned something.